Good morning and welcome, members and the public, to the first meeting in 2013 of the Health and Sport Committee. As usual, can I remind those present to switch off all the mobile phones and Blackberries, as they can often interfere with the sound system. And the first item on our agenda today is the general evidence-taking session involving Healthcare Improvement Scotland and the Scottish Public Services Ombudsman. Our first panel today is representing Healthcare Improvement Scotland, and can I welcome Dr. Denise Coia, Chairman, Susan Went, Director of Evidence and Improvement, and Robbie Pearson, Director of Scrutiny and Assurance, and Ian Smith, Regional Inspector, and Dr. Brian Robson, Executive Clinical Director. I think we have previously agreed that Dr. Coia will give an initial statement and then we'll move to questions if that's okay. So please take the floor.
Thank you very much, Convener. You've introduced my team. Can I also give apologies from our Chief Executive, Dr. Francis Elliott, who's unfortunately on annual leave today. To be very brief, it would be, I think, helpful just to tell you a little bit about who we are and what our roles and responsibilities are. And you do have a briefing from us, and as you know, we were set up in April 2011 under the Public Services Reform Scotland Act. And we've really got two purposes. The first one is to support healthcare providers in Scotland to deliver high-quality, evidence-based, safe, effective and person-centred services. Our second purpose is to scrutinise those services to provide public assurance on the quality and safety of that care. And we do that through three functions, and we've structurally realigned our organisation to deliver them. And those three functions are evidence, improvement and scrutiny. And you know of our evidence work through Scottish Medicines Consortium, SIGN and the Health Technologies Group. We drive improvement programmes and have national patient safety programmes. And we also provide technologies, improvement technologies at the coalface for clinicians to drive improvement within their own services. And our third function is scrutiny, and we have a number of programmes, and my understanding is your key interest is in perhaps the scrutiny programme around older people in acute care. We talk about these three functions as a continuous cycle of improvement, because I think the key point we want to get over to you today is that although we are a scrutiny organisation, the improvement component is absolutely crucial, that one doesn't happen without the other. So it's really important that not just how health boards react to our findings, but in fact what they actually do about our findings. And we are unique as an organisation in that no other organisation, I think apart from one in the Netherlands, provides scrutiny and improvement within the one organisation. And wrapped around all those three functions, we have the Scottish Health Council that's part of our organisation to make sure that the public and patients are at the centre of what we do. Another major strength of the organisation is the powers that we have under the new Act and under which we were formed, because we have a duty of user focus, a duty of cooperation with other organisations in the public sector, and a duty to publish our reports. And I think we're still learning the full extent of our powers under that Act, but it would be to highlight that to you. We're a new organisation and we're still developing, and we've had to hit the ground running. We've developed a new structure to try and really improve our capacity and capability as an organisation to meet our growing portfolio of work, particularly under patient safety and scrutiny, and we're growing our intelligence base. Just to end, we've got two challenges, we think, in the future. One is to demonstrate the impact of our work to both Parliament and the public, because as an organisation, unless we're making significant changes for patients and the public in healthcare, really were not much value. And the second challenge I think we've got is to look at the patient journey over time. At the moment, a number of our programmes are focused on acute care, but most patients spend most of their healthcare journey in the community. So our focus over the next couple of years is to really look very clearly at community services and quality assure healthcare, both in them and primary care. And that's really all I would say.
Thank you very much for those opening remarks. And can I ask some sort of general questions in terms of, you know, the role and the priorities that you've laid out, and noting your submission, and it's something that we've asked, you know, in previous about the capacity to fulfil those roles and commitments and priorities, because you know that you know the tasks under improvement, support and scrutiny, the prisoner health care, healthcare, environment inspection, you know, the improving learning, you know, there's lots and lots to do there. And we know as a committee that special health boards, in terms of their funding, you know, hasn't been maintained. So what is the funding position and the capacity in terms of your organisation to carry out all of these roles?
I'll briefly answer that question and I'll hand over to my two colleagues. I think I have to be perfectly honest, it would be lovely as a chair to always ask for more money, and it would be nice to say that we require additional resource. I think that one of the important things we've had to do as a new organisation is try and make sure that we have the right people within our organisation in the right place. So trying to internally, to start with, focus our capacity and capability. And because we have new functions within the organisation, we've really spent this year doing that. Yes, we did take a larger percentage hit than perhaps territorial boards, and times are very difficult in Scotland at the moment. Our key issue at present, though, is that we feel that to take on additional work, we would really struggle without additional resource. But our main priority at present is to stabilise our core funding, because I think if I hand over to my colleague on my left here, he'll tell you a bit about some of the arrangements about our core funding and programme funding, and it's much more about sorting that out than looking at additional resource.
Yes, thank you. Just to echo the point, this is about our skills and competencies to do the roles that are vested in us under the Public Service Reform Act. We have core funding of around £16 million from the Scottish Government. That's our core allocation. In addition, that's enhanced with additional funding we receive from the Scottish Government for a range of initiatives, such as within our safety programme. However, I think that what's important is that we have the skills and competencies and capability to do the task that is placed within us in healthcare improvement in Scotland, and that's what we're giving some active consideration to as a young organisation that's maturing. And if I may, Convener, just for a moment, dwell on my directorate, which is Scrutiny and Assurance. We have a team of around 45 people in that directorate, which includes around 12 inspectors. We're developing that skill and competency and capability, and thinking about what the skills and capability we need to inspect and to regulate as we do within the independent sector. And that's a mix of skills and experience that we bring to bear within the directorate, and also increasingly thinking about how do we draw on the skills and experience out there in NHS Scotland to help us do our work in scrutiny and assurance.
Susan, you might want to comment on the improvement side.
Thank you. Thank you very much. The improvement function is part of, or half of, the evidence and improvement function. So my directorate, which has just over 100 staff, has both those remits within its core function. So the evidence portfolio, which includes things like the sign guidelines, as Chairman has outlined, but also the improvement programmes, which include the safety programmes, other improvement programmes such as the more recently initiated person-centred care programme, Much of our dilemma in the improvement portfolio is the one that the Chairman has identified. Much of the resource associated with that, delivering that programme, comes in small pieces over 1, 2 or 3 years of funding, rather than core funding, which allows us to flexibly use the resource across the entire portfolio of work.
But our clinical engagement strategy does give us additional resource in terms of people, and you may want to comment on that.
Yeah, so we have a small core clinical team in the organisation with a chief pharmacist, a chief nurse and allied health professional, a consultant public health medicine and myself. But we have an engagement strategy that means that we bring in national clinical leads from the service, experts in their field, to work with us. At any one time, we'll have 20 or 30 of them working with us on a sessional basis to help us support our improvement programmes. But beyond that, we literally have access to thousands of clinical staff across not just the NHS in Scotland, but across the UK and internationally to help us with our work. So we do not have a large employed clinical staff, but clinical staff and clinical assurance runs across all of the programmes.
So you have more or less money in 3 years' time to carry out this, and what efficiencies will you have to put in place over the next 3 years to do all of this? Build up your capacity. Supposedly, I presume that the 12 inspectorates, have they got the clinical background, or do you need to depend on the service that you are responsible for inspecting and regulating to provide you for that resource? And I wonder how you maintain that level of independence if you're, I'm all for partnership, but if you're in a situation where you're dependent on the service itself or the wider resource, I wonder if that brings into question the independence of your operation.
I'll hand over in a minute to Robbie Pearson, but I actually think what's important for us to say as an organisation that over the last year, because we acquired a whole range of other groups and bodies coming into us as a new organisation, we've been very clear as a board over the last year that we have put together for next year what's called a local delivery plan, and that we have started very clearly, and we have a prioritisation process within that. So I think what's important is to actually say we can do X number of things and we can do them well, and to be very robust. And you're quite right about partnerships, because this is where independence comes in. I think we have to say this is what we can do well and what we will actually major on in the next year. This is what's important to the public and patients in Scotland and to delivering good healthcare in Scotland. Other pieces of work that perhaps are less important or have been inherited bits from the past, we've been quite robust, extremely robust in reviewing over the last while. And our directors, we had a development day just about a month or two ago to actually really focus down on us as an organisation, not the partners, not Scottish Government, what's important to deliver. But you, Susan, may wish to comment to yourself, Robbie.
If I start, just the 2 points, particularly that you raised, I think I'm certain that as far as the evidence portfolio and the improvement portfolio is concerned, it's vital that we do engage through our contacts with the service, either through clinicians or directly with teams working on the ground in the boards with the staff who provide the care. That link is a vital part of ensuring that the programmes that we draft and design and deliver are relevant to the service, that they make sense, that they're understandable, that they're deliverable, and they're targeted at the issues which are real for the staff, for the patients, and for the families. So I think that's a vital part of our working arrangements, and one that I think adds huge value. In terms of the reality of life, The NHS is constrained, like all of the other NHS organisations. We do work to a defined budget. It is a limited budget and it is reducing. So we will be looking, we are now looking and will continue to look at any efficiencies that we can gain internally by teams working more closely together, by looking at ways that they can share staff, skills, competencies and resources between teams. And I'm absolutely certain that that will be part of the way that we work for a considerable way going forward. But if new work does come into the organisation, whichever portfolio it's in, then we will be under severe pressure to deliver additional new work within the existing resources that we have.
Sir Pearson.
Yes, thank you. The question was about exerting the independence of ourselves as a body.
You get less money over the next 3 years. How are you going to manage those efficiencies at the same time meet the priorities of your organisation as outlined by your chairman, Dr. Coia? What is the efficiency campaign? What is the efficiency savings that need to be achieved over the next 3 years? How will that impact on the organisation?
In terms of the raw numbers, the budget is declined from 16.7 million to 15.9 in 13-14, and 15.2 is the projection for 14-15 in terms of our core running costs. As regards scrutiny and assurance, the team that we have within the resources that we have is 12 inspectors, as I mentioned, and is a mix of skills that we have from clinical backgrounds and also from non-clinical backgrounds. What I would like to do over the next 6 months is to enhance that by bringing in a range of skills and experience from the service and thinking about our specialist dementia nurses, our dementia champions, thinking about the public patient voice as well, which is fundamental to the public assurance that we have in our inspection reports. And how do we thread that professionalism, that expertise into our inspections? It does not take away from the independence and the voice that we have as a body, but ensures that we have a breadth of skills and competencies to support our inspections. And that's what we're starting to think about. So we have inspections and we can bring in other expertise as appropriate to enhance those and to give a level of perspective and experience to bear in our inspection reports, whether it's older people or there may be other aspects of work, such as our work in the review of adverse events within NHS boards. 12
inspectors, not enough. You've considered that's not enough. You need to increase the capacity of that. How many do you need?
I think we can probably have more inspectors to support our work, but and that's what we're currently reviewing at the moment as part of our directorate review within Scrutiny and Assurance. The directorate is being developed, and the intention is over the next 6 months it'll be further developed and enhanced with some of the messages I've just conveyed. The current planning that we're looking at is maybe for another 2 or 3 inspectors to support our work. But I think what's fundamental isn't about the raw numbers here, it's about the skills and experience and capability and competence that we bring to our inspection work. And that again emphasises the importance of the additional expertise that we may bring from the service. Picking up the point that Dr. Robson made earlier about our clinical engagement strategy, how do we use the breadth of experience and skills that is out there and expertise to support us in our work as a relatively small organisation?
Could I come back at that as well, Convener, in terms of our joint inspections? Because when you're talking about core numbers for our inspections within the NHS, we are also engaged with the Care Inspectorate around inspections of adult services and children's services. So we are also a contributor, if you like, to integrated inspections over the next couple of years. And part of our contribution isn't just raw numbers of inspectors. It's contributions in terms of improvement methodologies and specific methodologies and evidence bases. So there's a range of things we contribute apart from people and in terms of specialist expertise. So I think it's important to balance that. I'm sure
we'll get to some of that detail, but I think it's important to put it into context that you've got a reducing budget, that you would, if possible, increase those inspectors. That would be desirable. and indeed efficiencies will need to take place all at the same time of carrying out. And if we got any additional responsibilities, you'd be hard pressed to deliver on those responsibilities. Is that fair?
Absolutely agree with that summary.
Mark MacDonald, followed by Nanette Millen.
Thank you, Convener, and thank you for attending this morning. Can I ask, at the moment, what sort of percentage, roughly, would you say were proactive and what were reactive in terms of the inspections that you're undertaking?
Well, we have a mix of inspections. We have the mix of the Healthcare Environment Inspectorate and its work around HAI. We have inspections as regards the independent sector and the regulation and scrutiny of the independent sector. And we also have inspections relating to the care of older people. In raw numbers, if we could just give you some numbers to put around that, we have around 30 chiefly unannounced inspections each year for HAI. The number for the independent sector, and Ian might keep me right on this, I think it's about 16 a year. And the number for the older people's inspections is again around 13 so far that have been undertaken. So in total, we've got around 50 or so inspections a year. There's an increasing emphasis on moving towards unannounced inspections. And indeed, if you were to speak to the service, the clear message from the service would be they value unannounced inspections rather than preparing for an announced inspection. And increasingly, you'll see a greater weight towards unannounced inspections within the service.
I think where I'm going with that, though, as well, is that obviously you will have a plan for your year of who's going to be inspected and when, but there are always going to be occasions where events will overtake that and complaints will be received which will require inspections to take place. So I'm just wondering what the prevalence of such incidences would be. So you say you've got 50 inspections per annum roughly, which are what you start out planning at the beginning of the year, this is what we're going to do. How many unplanned inspections do you encounter during the same time period, roughly?
Okay, I'll give you a broad statement and hand over to Ian in terms of our responsiveness to that. It varies according to the area that we're inspecting or regulating, but each quarter we produce a quarterly inspection plan, and we do from time to time, as you infer, have to adjust that inspection plan according to events, and Ian might want to pick that up in respect of point of detail.
Yeah, sorry, Convener. Yeah, at the moment, for older people inspections, we've carried out 13 in total. 2 of those have been follow-up inspections that really came from issues that we found within the hospitals that we visited. One of those 13 as well was our first unannounced inspection for the older people inspections. Our follow-up inspections are in general based on previous inspections to a hospital which have raised concerns that we feel are important, significant enough for us to go back and inspect that hospital.
I'm still not 100% sure I'm getting the information that I'm looking for here, so I'll word it this way. You have your inspection plan either annually or per quarter. If I, as a member of the public or as a member of staff whistleblowing, contact yourselves and say there are issues at this care home or this independent provider, how quickly are you able to react to that complaint in order to factor in an inspection that would relate to that?
For the NHS inspections, we don't investigate complaints. It's not our role. The boards themselves have to investigate the complaints. We would take the intelligence from the complaints and use that to inform future inspections. With independent healthcare, we do react to complaints, and where necessary, that can be an inspection next day, or it can be follow-up. Depending on the significance of the complaint, it will usually be initially followed up by a phone call to the organisation, and then, if appropriate, follow up next day to the organisation.
Can I ask what criteria you use to determine your inspection timetable? Is there, do you have a spreadsheet, as it were, showing when premises were last operations were last inspected, or is there a different kind of criteria that's used to, are some, for example, likely to be inspected more regularly depending on what's been found in previous inspections? What's the criteria that's used?
Convener, if I make a general point and then Ian will pick up the detail around this, we're increasingly maturing, as Dr. Coia made earlier, an intelligence base to inform our inspections, and that will require us to work more closely with other regulatory bodies in Scotland and in the United Kingdom, but also thinking about our professional regulators as well, such as the General Medical Council, and that is something that we're maturing, thinking about that, how that hard data, whether we have information and intelligence from Information Statistics Division or other data, for instance, from our Scottish Safety Programme, but also increasingly how do we use the more granular information at the local level, at the ward level, at the hospital level to inform our intelligence and ultimately how we shape our scrutiny programme. But Convener, Ian Smith may want to answer the specifics in respect of the intelligence used to inform our inspections at this point in time.
Thank you. For the older people in acute care inspections, we had no baseline really to work on because they were new. The risk assessment was put in place, and it was using there was 6 areas put together. There were the generic measures for quality and safety. Measures of quality were put in for relevant to older people in acute care. Patient experience data, which was very, very important, staff engagement data, complaints and adverse events, and there was priority topic areas for nutrition, pressure area care. That was then put into a risk matrix where we now have, I think it's 18 hospitals on that, and it's in terms of risk from this data. As time goes on, we would use our own data in terms of previous inspections to inform inspections thereafter. For the healthcare environment inspectorate for the healthcare associated infection inspections, we used data based on our experience of the previous 3 years of where the hospitals are in terms of our risk rating of them. We also have started to use the prevalence data that came out from Health Protection Scotland and their prevalence report, and that also informs the inspections for healthcare associated infection. For independent healthcare, initially the commitment was to visit every facility within Scotland. However, we do take a lot of intelligence from that, of complaints, notifications that are put into any issues that arise from inspection, and we use that to then plan future inspections to those areas.
You mentioned relationship with other regulatory bodies. We took evidence recently from the Health and Safety Executive, and I wondered what your relationship with them currently is and how closely you work with them in terms of the inspection regime that both organisations are carrying out.
We have a memorandum of understanding with other bodies such as the Health and Safety Executive. We have a close working relationship with them, and issues of concern we obviously share intelligence on, but Ian, you may want to pick up that point.
Yeah, whenever we started older people inspections and the healthcare associated infection inspections, we developed an MOU with several organisations, including the Health and Safety Inspectorate, and since then we have, I think we've escalated 2 instances to the Health and Safety Executive, and they inform us if they have any issues in hospitals. However, it doesn't always fall within our remit to do that, to investigate, but what we will do is bring anything we find to their attention.
And can I ask how much sharing of information goes on in terms of forward planning of inspections to ensure that where organisations are planning their inspections, they're not all turning up at the same place to carry out perhaps different or conflicting inspections?
One of the ways that we're starting to do that is about sharing the intelligence. We probably don't do enough of that at present in giving sharing, if I may say, of the actual inspection programmes with other bodies. What we do, though, internally is increasingly think about what's the burden of scrutiny that we're bringing ourselves as Healthcare Improvement Scotland, and how do we manage that across the piece? Because inspection is only one part of a broader scrutiny and regulatory landscape within Healthcare Improvement Scotland and beyond. And I also think that one area where we can deliver greater integration of our scrutiny is with the Care Inspectorate, and we're starting to think about and pilot work for that sharing of intelligence and sharing of the scrutiny in a more integrated way with the Care Inspectorate that takes away perhaps the focus on the acute hospital setting and gives it appropriate place, but thinks about the journey of care for individual patients from home into hospital and their support for discharge and support back into the community.
Presumably there's nothing that would prevent organisations from sharing that kind of information to ensure that you know, the inspection landscape is as streamlined as possible and ensure that there isn't duplication of effort taking place.
Absolutely, and it's fundamental to the Carrera principles that we should be doing that as scrutiny bodies and minimising the burden on those that are scrutinised.
Can I also add to that both myself and the Chief Executive sit on a group that's chaired by by John Bailey in the Accounts Commission, which has all the scrutiny bodies in the public sector on it, and that group exchanges information. It's quite a practical working group underneath it to make sure that we're exchanging methodologies, to make sure that we're trying to streamline as much as possible, and that group probably is going to grow in influence over the next couple of years, because we would also like to share some of the training of our inspectors as well for core sort of modules.
Okay, thank you, Commissioner.
Just for the record, in terms of our discussions with the Care Inspector, we had long discussions and concern about announced inspections, unannounced inspections, and indeed the frequency of inspections and the themes and how many themes would be inspected on that visit. And they have changed their practice. Do you match that practice and frequency, you know, in terms of, will each of these settings be inspected on an annual basis? Will there be an announced inspection on an annual basis? You know, we've had 13, one unannounced. I don't think there's anything happening in the long-term care settings yet, is there?
No, if I may develop that point about the work with the Care Inspectorate, we are actually just meeting this week as a new programme board to develop and shape our approach to multi-agency integrated inspections for adults in the community. And in doing that, there's a real opportunity to share our different methodologies, and the methodology from the Care Inspectorate with the work and the intelligence and approach that we take within Healthcare Improvement Scotland to our scrutiny. And the intention from that is to test the methodology for integrated inspections for adults within up to 3 local authority areas in the next 4 or 5 months. And that will be an opportunity to share skills, experience and learning, and also in a more practical way, I suppose, the sharing of the methodology and how do we increasingly paint a picture of that journey of care from home into hospital and out again as an effective support and rehabilitation to maximise independence for individuals.
I'm sure we'll get some questions on that pathway, but at this point, on a request from the Cabinet Secretary, you know, announced, I think, at this committee that the acute settings and elderly care were going to be inspected. What was agreed, what would be inspected, the frequency, and when that inspection process was to be concluded?
The Older People's Inspection Programme commenced in February 2012 with the Western Infirmary in Glasgow, and it was agreed that every NHS board would receive an announced inspection in the first instance, followed by unannounced inspections thereafter. We've concluded 13 inspections. They have been chiefly around the Greater Glasgow and Clyde, Lothian, larger board areas. We will be carrying on with that programme of, in the first instance, announced and unannounced inspections, and taking stock, as we are at the moment, of how that methodology is working. And that review group has had a number of meetings, and it's led by Pam Whittle. That opportunity that we're taking now is to review that methodology and its robustness, and that work. Does that
mean one inspection per month per health board?
It's roughly, it's been probably a little bit more than that, given we've done 13 inspections and started in February, and the last inspections we've undertaken were, and the last report that was published was for the Western Isles. We will be going back to the programme of announced inspections in the next month.
So when will you, that would be for February 12, when will you conclude all of the inspections that need to take place under the agreement instruction with the Scottish Government?
We will be concluding that probably by the first half of 2013-14.
It's a long time.
I think we've taken the time to get it right, because this is a complex programme of inspections, and it's different in a sense from the HAI inspections, because it's looking at the systems of care within the acute hospital setting for older people. So I think we're getting it right, and we're learning from it, and that's why we're undertaking the review of the methodology, so there's opportunities to build in more learning and opportunities also to strengthen the improvement work that follows from these inspections.
But compared with the care inspector, compared with the care inspector and their responsibilities to inspect residential settings, they're expected to do that on an annual basis. Each of these areas are expected and inspected on an annual basis.
Could I make a general point about that? Because as a board member, I sit on the board of the Care Inspectorate. The Care Inspectorate's inspections are regulatory inspections, so this is for care homes to receive licences. And so therefore there are quite strict rules laid down about sort of the frequency of those inspections, and they have an impact on whether that care home can function. We are not a regulator in legal terms. We scrutinise and quality assure, and the difference between the inspections in older people in terms of scrutiny, because they're not regulatory inspections, so we have no mandate to go around hospitals for in a cycle, if you like, in the way that the Care Inspectorate does that around care homes. The issue for us, and the crucial one around older people particularly, is around the culture of care. So it's not so much the frequency of the inspections that are going in, but what we're finding when we go in for those inspections, and how we then, when we've identified some issues around the culture of care in acute care, how we then work with our improvement colleagues and with our clinical engagement to actually make changes to that. Because the difficulty we've got is we could keep inspecting and we could keep finding things wrong or extremely good, but then if we don't change that, and the big issue that I think came out of the Lothian work with Anne Jarvie's review in 2006 was identifying problems and then not putting in sustainable solutions to them, led to a further inspection from us 4 years later where there's no change. So I think what's really crucial for us is actually not the frequency of the inspections, but when we find issues, how can we demonstrate over time that those issues are changing in NHS Scotland? And I think that's particularly crucial around care of the elderly in our hospitals and care of our elderly at home, because the Care Inspectorate is discovering the same issues. So our joint inspections that we're putting forward in light of the integration of health and social care, when we start to look at quality assuring pathways of care, are really about what is care like along that pathway for the older person as they travel that pathway, and what's their experience of it. So it's not the frequency, it's about whether we've actually really changed anything.
I think we'll definitely come to pathways and indeed care standards during the course. Nanette Millen?
Yes, I'm not sure, I'm slightly confused. I wasn't on the Health Committee at the time that previous inquiry was done, so I'm kind of learning a bit about that as I go along. But I found, according to your website, your reports published so far cover 5 NHS boards. is that all to do with this elderly care, or is this sort of just general inspections? And why did you actually focus on these particular 5 boards initially?
In terms of the older people's inspection, we made a judgment about population size, but also the areas where were identified in the rating, and there was a number of factors which Mr. Smith referred to earlier as indicators, and that may be issues of infection, maybe issues of readmission rates. So there's a range of indicators that we've considered in building that picture. And increasingly, that intelligence is going to develop and evolve and become a bit more sophisticated, and thinking about the more granular information and intelligence that we have at the local level, whether that's complaints or indeed other intelligence we have from system and professional regulatory bodies. So that's something that's evolving and something we need to invest in and think about how we use that in a more sophisticated way.
How much influence does the experience of patients and their families and carers have on your decision on which boards to inspect, or which hospitals to inspect?
In terms of public and patient involvement in our work, we give crucial importance to our work is the patient voice in our inspections. The older people's inspections, for instance, we have 2 public partners on those inspections, and they are crucial in ensuring that we're not just looking at the system of care, but we're also thinking about the experience for the patients in the NHS and for their families. And we collect questionnaires, we collect information from interviews with families, and we factor that and thread that into our inspection reports. We've also done that traditionally with the HAEI, and we also give some thought as to how to do that within the independent sector as well. So it's something that we're keen to develop and give that patient voice and ensure that that is threaded through the inspection reports, because that's fundamental to our role as an organisation, ensuring that we give that public assurance and that public voice is heard.
I understand that within the NHS you can make recommendations, but you can't actually enforce that. So what do you do after, following on from your report, to actually see whether your recommendations are being carried out? And do you make further recommendations, or what clout do you have, to ensure that what you're recommending is carried out?
We publish our inspection reports, and alongside that we generally publish an action plan from the NHS board which responds to that inspection report. If we have significant concerns, we can escalate them on the day. If we have further concerns, we can carry out a further unannounced inspection. But we also have a system whereby we're back to the NHS board 16 weeks after the inspection improvement plan has been published to follow up and seek updates on the actions. And if we're not satisfied, we'll be back to that board for a further unannounced inspection. So there is a process of inspection and scrutiny that follows on the back of the improvement plans. What's crucially important is that the NHS boards own and value those inspection improvement plans, and that they are demonstrating within their NHS board, within their governance system, that they are making progress.
If you did come across a really recalcitrant board that just wasn't responding, what's the ultimate sanction? Is that with the Cabinet Secretary, or who deals with it?
In terms of sanctions, we're not a regulatory body in that regard, that we've got enforcement powers, but we do believe we have very significant powers within the Public Service Reform Act which allow us to carry out our duties, and we do that in a way which I believe is proportionate and is increasingly risk-based. But that's a fundamental issue for us, an importance for us within the Act, that we're able to carry out our work which emphasises that it is about scrutiny, but it's also about improvement, and how do we facilitate that improvement within NHS boards.
But we do also have an escalation policy in terms of if we have a board that is simply not going down that route, whereby our chief executive can speak to the chief executive of that board. We can also refer beyond that to the Performance Management Unit in Scottish Government and to the Director General and our sponsor division within Scottish Government, and it can escalate from there up to a minister, and so there are ultimate sanctions. And Scotland is a very small country where you can go up that ladder fairly quickly if you need to. I think what's important, and maybe Susan will talk about this, is actually trying to put improvement in, to actually get some action by boards rather than constantly escalating. And maybe Susan, you're
The vast majority of boards do take action on the back of scrutiny and inspection reports. As Mr Pearson has identified, we do expect an improvement plan, which is owned by the board, by the organisation that's been inspected, to be in place after the inspection, or the information about the inspection and the details of the inspection has been passed back to the board. What we do have in addition to that is a responsibility for improving the services. So the lessons which have been learned from the collective reports from the first 6 months of the inspection reports, the care of older people in hospital, have been used to build an improvement programme to support boards, not just those that have been inspected, but the entirety of the Scottish system, to improve the services that they provide for older people in hospital. So the key themes, the key and consistent themes that have been identified in the inspection reports are those that are the centre of the improvement programme that we've already got in place. That programme started in April of 2012 and will run for 2 years, so until March 2014. The key themes that are embedded in that programme, and the ones that have come out of the collective learning from the reports, are about coordination of care, about the pathway of care, about making sure that it's consistent, coherent, and seamless from the family and patient point of view, and the assessment mechanisms, particularly around cognitive impairment, but also about assessment for specialised pathways, which may be delirium, dementia assessments, maybe frailty for the very frail elderly. So those are the core elements that are in the improvement programme, which is already designed and running.
And our clinical director could probably give you examples of where the improvement programmes are working in Scotland at the moment.
Well, I mean, just to follow up on colleagues' contributions, we have, although not every board has been inspected today, every board has been actively involved with us in learning from the inspections elsewhere. And as Ms Went has highlighted to you, we have focused down on the areas which are of greatest risk to patients. And we know these are areas of greatest risk, whether it's nutrition or cognitive impairment or areas of pressure ulcers. Those sorts of things are the things that we know that are the problems out there in the service for patients. We know that because clinicians tell us that. We know that because the data tells us that. We know that because patients' experience and relatives tell us these are the areas of focus. They are the areas of focus for the whole country, not just those boards that have been inspected to date. So the impact of the inspections to date is way beyond the number of inspections which have taken place. And the improvement programme, which has been launched earlier this year, has been widely welcomed by the boards across the country. And all boards are keen to be actively involved in that.
Why is it then, if all of that's been worked out and it's clear that everyone going in and dementia, cognitive impairment, should have an assessment, why is that not happening?
I can pick up there. I think in many cases it does happen. In many organisations, these techniques and skills are complex. The needs of the patients in the system are very complex, and sometimes the staff need help to identify not just what to do, but how to get those changes in place in a successful way. And that's the purpose of the improvement programmes. It's not just to identify the evidence and what should happen, but how to make the change in practice. And that does take time. Often, particularly for complex pathways of care, there's a lot of staff involved, many teams, several wards, often more than one organisation, and that just simply takes time.
I understand it's a challenge to them, but providing appropriate utensils to drink and to allow someone to be fed, to providing care that protects someone's dignity. We have seen these reports. Give me a good outcome to that. You've identified that situation happening in nearly every inspection you've went into. Every inspection. Now, you've sent that back to the health board. And what's a good outcome to that? What does the health board come back and say that you're satisfied with it, they have taken action? Just recognise that it's happened? Or do they get to a real understanding why the culture in that ward or that particular hospital failed that person? What's a good outcome in your inspection?
I think you have to separate the two acts, because I sense your frustration, which is also our frustration with that, where there are unforgivable events, if you like, and not providing utensils or speaking rudely to someone or leaving someone doing something which is undignified. There is no excuse for that. That's a matter of compassion and you don't need training for these kind of things. So I think there are events which are unforgivable, and there's events which are unfortunate because of the circumstances of what's happening in hospitals. So, for example, when pathways of care get blocked because there's not enough community services, and you find acute hospitals are managing patients that probably should actually be managed much more appropriately in the community, you can say that their care may be inappropriate at that point and we need to do something about it. But actually it's not completely unforgivable in the way that not handing over utensils.
You expect the health board, when they discover it and they're confronted by a breach of their own standards of care, what action do you expect that health board to take, and what action is the norm to take, and what's acceptable to you?
Well,
should it be disciplinary of the people that are in charge, or what happens when unforgivable events take place? What happens as a result of that inspection and that identification of a...
Well, I personally, as a chair, if we point out unforgivable events to a board, would expect them to fix them immediately. I wouldn't think there's any discussion beyond that. And when chief executives and boards are presented with unforgivable events, they are shocked by them. So I don't think I would expect that fixed instantly. We do ask them to produce an action plan, and my colleagues will discuss the action plan, that what happens with that action plan for events that are not so much unforgivable but as inappropriate, if you like, with that.
What the health board need to do is provide the utensils. They don't need to examine the culture. That's the amount of it. They would just say, well, we've put in place the utensils now and everybody has got those utensils.
I would hope so.
That's what they would do. So we don't ask them why there was a failure in that system, why there was a failure of compassion, why there was a failure of care.
We do ask them that. In their action plans, we're not simply looking for them to say they'll do it. They were looking for them within their own board governance arrangements to make sure that they do these things. Now, if it's a simple process of assessment, that's simple if you just look at it as just one element of care. But when you have to assess patients for a whole range of different elements of risk, whether it's risk to nutrition, risk of falls, risk of pressure ulcers, all of that is complicated. But we expect boards to understand what makes it complicated and simplify it on their wards to make that done more reliably. When our reports, these OPAC reports are fundamentally different reports from the reports that inspection processes have looked at in the past. They are looking at behaviours, they are looking at examples where we're giving verbatim reflections of what we heard and saw in the ward. They are very much, as you say, going to the culture of the ward. not just about whether you can tick a box and make sure certain things are done reliably.
The board and the ward manager is highly unlikely to say, well, really it was my fault because I should have got a bank nurse in and we were operating with one down, or you know, we should have had more people on. They're highly unlikely to admit that failure, aren't they?
To pick up this point, the issues that are identified in inspections where there are serious failings, they are directly escalated on the day by our inspectors to senior management within that NHS board. If there are further concerns that are identified that don't require immediate escalation, we pick them up through the improvement plan for that NHS board. But we take these issues extremely seriously in our inspections, and we will follow up on an unannounced basis where we've got concerns, and these unannounced inspections may be focused, they may be targeted, or they may be for a larger area of a hospital. So we do have a process of follow-up, and we do have a process of ensuring that that ownership is held by the NHS board in question. And if we go back to my earlier point about the improvement plans, they should not be a tick list. They need to address the fundamental issues that Dr. Coia referred to earlier about the culture of care and about leadership. Leadership is fundamental to this successful delivery of high quality care which respects dignity and privacy for patients.
The plans public, are they available to the committee?
Yes, the improvement plans are available, and we publish them on our website, and they remain on our website for a number of weeks.
Gil Patterson, followed by Bob Doris.
Thanks very much. Can I go back to funding, if you don't mind? But my question is in relation to funding for providers, and it just so happens, just yesterday, the Health Environment Inspectorate, your colleagues, gave St Margaret's Hospice in Clydebank the maximum score of 6 out of 6 in the categories, which is extremely high. I believe it's the highest ever achieved. But my question to you is in relation to funding. It just so happens that this hospice is the lowest health board funded hospice in Scotland. Now, that's a very parochial question. It's the place that I probably know the best. But my question is, do you look at funding or resources when you make an inspection? And do you take that into consideration when you make your report?
We don't directly take into account the funding of NHS facilities or indeed the independent sector. We look at the quality of care that's offered, and that may reflect a number of factors, staffing and funding.
That would lead on to another question in regards to viability of an institution, whether it be a hospice or otherwise, that may affect the delivery of the service. Have you any tools in the box to scrutinise that? I know that you can't enforce it in any way, but do you take that into consideration, bearing in mind this committee's work with Southern Cross, if you have that on your radar at the present time?
We don't directly have a toolkit for doing that. What we do take into account is, as I say, the quality of care that's offered. We are very clear about where our responsibilities begin and end in relation to the provision of care and the accountability and governance and financial governance of institutions, whether it's in the NHS or outside the NHS. We're very careful about not straying into matters which are the purview of the NHS board or the trustees of a particular charity.
Except for this, if in your expert opinion that some of what may be going wrong is due to funding and maybe causing lack of resource at the coalface, would you in some way put that in your report? Would that see the light of day? Would it get into the public domain in some way if you thought it was genuinely a problem, just like Southern Cross? Would we get to know about it through your work?
I don't believe that that's our role. There are other bodies such as Audit Scotland who have perhaps a more appropriate scrutiny role in that regard. But we do increasingly comment on the leadership and how that leadership supports the delivery of high quality care.
Thanks very much for that, Convener.
Thank you. Bob Doris.
Thanks, Convener. Good morning. I do want to talk about the inspecting the care pathway in a second. I think maybe given the line of questioning the Convener had, which was quite interesting about the distinction between unforgivable practices and inappropriate practices in an acute setting. I should first declare interest. My wife working in the acute setting as a nurse. Can we kind of create some discussion around that? By and large, is most care of a good standard and high quality, or is there a significant amount of inappropriate or unforgivable practices? Because I think it's important the committee captures, by and large, what you see when you inspect hospitals, when you inspect the acute setting. So by and large, what do you see?
Well, we can both answer that. I think you've made a really interesting point there, because I think by and large the care in Scotland, Scotland is a world leader in some aspects of healthcare, and I think in the acute sector in particular, if we just look at day surgery as an example, that has it's mushroomed in Scotland in a way that's a credit to the health service in Scotland. Our clinical director could more than tell you good practice that's going on in Scotland. I think it would be useful to touch on that before we talk about the rest of the practice. But I think the baseline, and I think what you're saying is the baseline in Scotland from our experience is that it's a reasonably high baseline. Now, in terms of care of older people and in terms of the pathways of care of older people, I think that's a separate issue, and I think we have a lot to say about some of the issues around the care of older people. But if you're looking at it in the totality, and I don't know if you want to come in on that.
Say, could you come in very briefly, because the intention wasn't to give you an easy ride in my question. It's mainly the opportunity to give you to put something on the record. Yeah. So perhaps just briefly, because I do have follow-up questions to ask.
I would just echo the Chairman's comment that by and large the care is safe and of high quality, and we report that in our reports, and we also report the areas of improvement that are required.
Right, okay, thank you for that. Now, the question will get tougher, I'm afraid. Hopefully not too bad, but now the culture's about health improvement, so it's not just about identifying where there's issues, but it's about how you improve the overall quality of the service, and I get that. So that's where inspecting the care pathway is for myself. Now, could you put some flesh on the bones for me? I'll give you an example. An older person is admitted to hospital in an acute setting, and Health Improvement Scotland are in that hospital at that time where that patient is there and you're doing your inspection. Can I expect you to look through that patient's notes? Can I expect you to work out, was the person at home? Was the person in a long-term residential unit? Can I expect you to go back to the social care assessment which was done for that individual? Can I expect recommendations to be made about why that old person found themselves in acute care in the first place and what should have been done to prevent that from happening? Because for me, that's what inspecting the care pathway is about. And I just want to make sure when we do move down that road, it's not just a tick list of was this done, was this done, was this done. It's about driving improvement for the individual. So can you bring it to life for me about what inspecting the care pathway actually means?
I think Mr. Pearson actually presented exactly this to the chairs group yesterday, so I'll leave him to tell you that story. Mm-hmm.
Yes, we currently inspect on our older people's inspections and review the case notes, such as for nutrition, such as for cognitive assessment, and we do that when we're on our inspections. The point about how do we capture more broadly the journey of care for patients and where there may have been an element of service failure that precipitated admission to hospital, and how does the service support discharge from hospital into the community, and what support is there for rehabilitation and maximising independence. Getting that picture, painting that journey of care is increasingly important when we think about a more holistic approach to the provision of care. What we would like to do in developing our inspection methodology for the care of older people is to do a more formal case note review. So we can take a sample of perhaps 20 or 30 patients and look at their journey of care over a period of, say, 6 months, and to see the factors that supported them at home. It may be informal carers, it may be in social work, it may be aids and adaptations. The patient may well have fallen at home, may have been admitted to hospital with a fracture hip and then supported in hospital, and how is that support in hospital allowing them to be rehabilitated and then back home again. Now, telling that picture requires us to think about how we draw on a range of case notes and a range of pieces of intelligence to form that picture, and that's something we're going to test out as we develop and evolve the inspection methodology. But it will also be a tremendous opportunity to connect that inspection work and that review of the case notes with the multi-agency, with our agency integrated inspections with the Care Inspectorate in the community as well. So we can tell a journey of care for individual patients and their experience. But Mr Smith may wish to comment more directly on how we use case notes to inform inspections at present.
Yes, thanks, Mr Pearson. At the moment, we follow the patient's journey from admission to the hospital, and that will focus primarily on our topics for the day that have been assessed as been important through the self-assessment and have been identified of areas that we wish to look at further. So it's from the point of admission to the hospital, and then we follow through to where the patient is at that moment whenever we're inspecting. So we're looking at assessments, we're looking at care planning. We then follow that through and looking at the care at the bedside. We at present, in our current methodology, we don't look at previous care within the community and how that's then planned for the discharge planning for the patient to go home. From an inspector's point of view, I think that is an area where we should be going, and I think we'll get there for the integrated adult inspections. I think the two will complement each other, and I think that would be a positive way to go for the patient, and addressing what the patient's needs are, which is, from an inspector and from the organisation's point of view, is central to what we do.
Just check, do we have to wait for the integration of health and social care bill to do that? You're doing some work just now, so I assume you're talking about a joint inspection team with the Care Inspectorate that would look at not just, so when you start the inspection in the acute setting, you look at all facts, including pre-admission, and you would have inspectors from the Care Inspectorate doing some joint work with you. If that's what we're moving towards, when can we see that starting in a pilot?
Pilots, so I think you want to discuss.
Yes, we're starting work with the pilots in the next month, and with several interested local authorities where we have the opportunity to work together to test this methodology out. But as Mr Smith referred to, is we'd like to see this as a journey of care, so it's how the older people's inspections within the acute hospital sit within that overall scrutiny of the care of older people, and that's something we'll give some thought to. Picking up the earlier point about being careful and thoughtful about the burden of scrutiny on the NHS, but also within the local authority as well. So that's something we have to think about, so there's an understanding how this comes together as an integrated package and programme of scrutiny.
And could you tell us what the first local authority you're doing this in then? I mean, you said there's 3 and it'll start soon, so yes. Where's first up?
We're in discussion with Pearson Kinross Council, and we have the first meeting of the multi-agency board on Friday to consider how the methodology will work in practice, and there's 2 other local authorities we'll be engaging with over the next couple of months as well.
So indulge me further on this, because I've got a genuine interest in this area. So let's say you go into an acute setting in Pearson Kinross and there's 10 patients that you decide, 10 older people you decide to look in a bit more detail. If someone's been admitted for a slip, trip or fall, will you be wanting to assess whether or not that person suitable adaptations in their house? Would you want to assess whether there was a continence check done in that older person? How much detail are we getting into it, and will this actually drive recommendations ahead of full health and social care integration about how local authorities should change their practices?
We will be looking at individual case notes and looking at the coordination of care within primary care with social work teams and the extent to which there's a journey of care which is integrated in supporting people into hospital and supporting their discharge again. So we will track patients and the journey of care, but Mr Smith may want to comment on the detail of that, what it might mean.
From my perspective, it would be if a patient had a failed discharge, whenever the patient comes in, the appropriate assessment is carried out, and then the journey would be, has that been recognised as part of the assessment and then gone through to the discharge planning? Has any learning occurred from that patient's journey that would make the patients stay in the community better and where the patients tell us they want to be, and then that should then link in as well, so we then have the loop of the scrutiny to tell us if that's worked.
Can I ask another couple of brief questions? And I know my colleagues want to come in. And I'm looking at the themes by which you inspect care for older people in acute hospitals, and I see dementia and cognitive impairment there. But would that include, there's nothing that actually mentions mental health and well-being there, and I think social isolation and happiness and well-being of older people is pretty fundamental to have them happy and healthy in home. Is there any assessment done in relation to the general mental health of older people?
Come in that because actually I'm a psychiatrist by background. I think what's important in the cognitive impairment is that, and that's why it's dementia and cognitive impairment, because for many older people who are depressed, part of the problem with the depression is not requiring to have a full mental health assessment, but actually they become cognitively impaired as a result of their depression. So it's a very good proxy indicator, if you like, to pick up for that. And I think that's why I personally was very keen when we were looking at inspection of older people, that we didn't just look at dementia, that we looked at cognitive impairment, because it's a very good proxy measure of what's actually going wrong in an older person's mental health. So we don't do a full mental health assessment as such, but I think picking up on cognitive impairment starts to begin to get into that area that you're talking about.
Very much, very interesting. And the final question, I was mentioning obviously that care pathway and speaking to different agencies. What about for older people, carers? Are we engaging with carers in relation to that overall inspection process? Because when we've previously looked at work from this committee, sometimes they're not necessarily listened to as much as they could be to inform inspections.
There's two parts to that, if I may. One is that we obviously, in our older people's inspections, take time to interview carers as part of our inspection, and we have a number of verbatim accounts that are threaded through the actual inspection reports. So that's captured as well. I think what's also increasingly important is that we think about that carer dimension in the integrated inspections and the extent to which informal carers are supporting individuals at home, and if that informal carer becomes unwell, what is the support mechanisms to support those that have been cared for to remain in their own homes. So that will be part, I guess, a part of that design of our integrated inspections with the Care Inspectorate.
And managing a lot of change, hopefully positive change in the next few months, I'm sure we'll follow it with interest. Thank you.
Richard Simpson.
One quick supplementary for my main question. In terms of the new methodology for examining care pathways, will you be publishing that on your website?
We're very happy to do so, and indeed in openness and transparency we make sure to do that and make sure that's available jointly with the Care Inspectorate. That'd
be welcome. The new Patient Rights Act has tried to introduce a new system whereby there are the 4 C's: compliments, comments, concerns and complaints, so that people don't feel they have to go into a formal complaint process, can make an observation. I mean, I have an elderly relative just been admitted to care who's got cognitive impairment, and in terms of her medical management, I have absolutely no concerns whatsoever. but she is cognitively impaired, and therefore, feeding her, making sure she's taken to the toilet, etc., is important. But one of my relatives going in, saw a patient lying in an accident and emergency section or booth or whatever you like to call it. An elderly lady with a catheter in with a nightgown halfway up her body, which I regard, and I'm sure you would, as an unacceptable behaviour. The fact that that can happen and nobody actually observed it. My point is that in the new system, we've got to find a way of actually engaging all the observers, families, and not just the families in relation to their own carers, but in relation to others. Is that something you're asking about people saying, did you observe anything, not just your own family, not just your own relative, but did you observe anything within the ward which you felt, you wouldn't like to happen to you, or you wouldn't like to happen to your relative?
Mr Smith, do you want to comment on that?
Yes, thanks. Yes, part of the process is we speak to patients, as many patients as we can on the wards. We also speak to relatives, next of kin, carers. We have the Princess Carers Trust who come as part of the inspection, and they speak to patients or relatives at the door. So we do try very much to get the viewpoint of patients, carers, and feed that through into the report, and also to inform the inspection on the day. And we also feed that back to the authorised persons within the board. If it's an immediate concern, we escalate that at the time. If it's part of the inspection report, or if we will raise that with the accountable officers at the end of the inspection as well.
And I know you said that you don't deal with complaints, and that's quite correct, but the boards now are supposed to take together all these concerns, comments, complaints, so that they can aggregate them, and the board is supposed to have a report. Do you get access to those reports? Are you sent those reports by each board each month? I don't know where we are with implementation of the Act, but I mean, have you actually got to a point of saying to the boards, we want to get your monthly or quarterly reports on comments, so that we can see what you're doing with them, how you're aggregating them, how you're looking at the culture? Because as I entirely agree with Dr. Coia, that our problem is not the acute care, which I think is of a very high standard. Our problem is the culture of the underlying care, particularly of people with cognitive impairment, which is the massive challenge for the service. So are you getting reports from the board yet? Are you going to get reports from the boards?
I see them as yet, but there is being work done, and Susan, you maybe want to talk about that.
Yes, it's a supplementary, but I think goes to your comment on your colleague's earlier comment about using the examples, whether they be personal examples or those that have been cited by individuals in the care system. The improvement programs, whether that be the older person's acute care program, the person-centred care program, any of our safety programs, uses very, very strongly stories, exactly the sorts of examples that you have just quoted, patient stories or carer stories to inform the work that the teams do. So they're not hypothetical examples, they are real examples. Some may be taken verbatim, some may be taken from inspection reports or complaints. We use all of those sources as examples of things to lever the learning. So why did this happen? What should have happened that did not happen? And how can the processes of care be changed so that the outcome of that process of care is more reliably good and less indifferent?
Can I just ask one more specific question about the inspection system? The boarding out is a problem with hospitals under pressure, and you can determine, I think, to some extent what's happening by the levels of boarding out and the frequency of shifts, not just moving from the surgical ward to another ward, but if they're shifted on. I mean, we've just done an FOI showing that the worst example was 18 shifts within a hospital. I mean, that, I hope the person was fully cognitively aware. If they were slightly impaired, that was appalling. But Are you convinced now that every hospital, as the Cabinet Secretary, the previous Cabinet Secretary promised, has got a boarding out monitoring system in place, and that that is linked to the cognitive assessment so that those with cognitive impairment are not being subjected to shifts within the hospital, unnecessary shifts?
We have identified that as a recurrent issue within our inspection reports, and you'll see that, particularly for those with cognitive impairment and dementia. But Mr Smith, we want to pick up the examples. And
From the inspection so far, most of the hospitals have a monitoring system for the boarding of patients. What they don't have in general is a monitoring system for those patients with dementia, which is part of the dementia standard. The hospitals themselves realise that they have to have that, and in all of the improvement plans that we've had back, the hospitals and boards actually are working towards that.
Thank you very much. And if I can just move us to a slightly different topic. In England, they have a system of alerts, incident reporting and alerts. And I just wonder, first of all, do we have that system in Scotland? And if we do have it, of sending out alerts, are we working closely with our colleagues in England? Because they appear to have a pretty good system of rapid alerts, but also monitoring systems. And I know we've got a very good patient safety program, but I just... the British Medical Journal no longer reports on Scottish things very much. They don't seem to give us much credit in these areas. And I just wonder if, how our system's working in that regard in terms of incidents and adverse events.
Right, so I was going to look for some clarification on incidents and adverse events, so Robbie would be able to give you a little bit more about that.
You may be aware we're undertaking 2 pieces of work nationally to review the position as regards the management of adverse events in NHS boards. We're reviewing all NHS board systems and processes as regards the documentation and the learning and ultimately the improvement from adverse events. Part of that is about technology. It's about the system of DATEX, and which is one system that's used very much across Scotland for recording incidents and adverse events. So we're learning from that whole programme of reviews. The second thing that we're doing is thinking about what is a national approach to reporting, measurement and learning look like around adverse events. And partly that is about leadership and systems and documentation and involvement of staff and patients in that. But it's also about the culture that supports that openness and the learning and transparency. So that work will be proceeding over the next 6 months or so with a view to us having potentially a new national approach to that. And I think our size and scale and opportunity for learning in Scotland gives us a great platform in that regard.
I don't know if Dr. Robson wants to come in on the incident side of things, but...
No, I mean, I think we're wrapping all of this up into the significant adverse event reporting to improve the reporting framework and the actions that are taken as a result.
And are you being consulted on the discussions over no-fault compensation and how that might affect or improve reporting in this area?
Well, we're aware of that consultation. There's a number of strands of national work that will come together in this to I guess sit alongside and complement the work on adverse events, and the work on the Scottish safety indicators is a good example of that, and also the recent announcement by the First Minister about the confidential alert line for staff. So there's a number of strands of work that can be supportive of that more open and just culture, whereby people do feel they have an environment in which they can raise concerns and have these concerns listened to and ultimately acted upon.
The final thing is that the government have acceded to the requests I've been making for 2 years to introduce a whistleblowers line nationally now. And have you had discussions with whoever's running that as to how you can connect into that so that you can pick up, fairly critical things that are coming in from staff?
Yes, we have. We've indeed, myself and a number of my colleagues from Healthcare Improvement Scotland met with Scottish Government officials just last week to discuss this new telephone line and what the potential role for Healthcare Improvement Scotland might be in that. and these discussions are ongoing.
Lou Smith.
Thank you, Convener. We've had quite a lot of discussion on this already, so I don't intend to dwell on it. But I mean, last year when Healthcare Improvement Scotland were in Glasgow and you looked at the GRI, the report said there was a consistent failure to respect dignity of older people, and the two examples of that would be the failure to assess around cognitive impairment and dementia, and then there were specific instances of I think what Dr. Coia would describe as unforgivable or unacceptable instances, such as people showering cubicles without screens, that sort of thing. I suppose the question that I think you've set out the difficulties you have around this as an inspectorate regime of you want the boards to fix these, as you said, immediately, and I mean I suppose by and large what my constituents would think of that is these things are the basics. You know, if we can't assess someone as to the ability to understand what is going on around them when they're in a cared for setting, something very fundamental is going wrong. And equally, if we're unable to respect people's dignity in terms of cleaning or toileting or anything else like that, that is a basic and fundamental problem. And it appears that there are instances of this across the reports that you're making. So how do you systematically then seek to deal with this? Because we can say by and large these are the minority of cases, but how do we get to a situation in 2 years' time, 3 years' time, and 5 years' time that we can monitor this? How do you then categorise what you describe as an unforgivable instance, versus there's a better way of treatment in this area and we want to roll out better practice, and that's well and good and should be supported. But where something is unacceptable, how do you categorise it and then monitor it against time to say that actually we recognise this as a minority of instances, but we want to see it reduce?
I'm going to have a response from both the scrutiny and the improvement side, because I think there's two answers to that, actually. So I think there's the quick answer in terms of scrutiny of how do you feed back these comments about completely unforgivable incidents. And I think that's what Ian was talking about, the instant escalation at that point.
Yes, we have an immediate instant escalation on the day of the inspection. If there are aspects of the care or indeed which may reflect leadership at the ward level, we will escalate those to senior management on the day. What we don't underestimate is some of the challenges in dealing with the culture. These are cultural issues that we're trying to address here as well as issues about the quality of care. And it's important that we have a process of tracking those improvements. And for instance, over that 6-week period, the extent to which there's been change and change has happened, and if we're satisfied or not with that, with the response from the NHS board, or we carry out a further unannounced inspection. But it's also important to reflect on the extent to which inspection leads to improvement. And if you go back to where we were with the Healthcare Environment Inspectorate when it was established in 2009, there was a wide range of concerns identified within those inspection reports, which were frankly pretty basic issues of infection control. And there were over 300 requirements and recommendations on NHS boards in the first year of the healthcare environment inspections. That's now, in the latest figures, dropped to below 200 requirements and recommendations. It's not to take away from that in terms of those requirements and recommendations, but we are seeing greater leadership, greater involvement of staff in infection control, understanding policies and procedures, and ultimately improved compliance. So that's an example whereby we can see actually improvements happen in practice, but also improvement is the whole improvement infrastructure that we have within Healthcare Improvement Scotland is fundamental to this as well. It's not about inspection and scrutiny in isolation.
And if I pick that up, I'll give you a couple of examples if it helps, but certainly the issues, immediate or longer term, that are identified as part of the inspection process are raised with the senior team. They're raised with the leaders on the wards, but also with the board team. And the expectation is that they will deal with those and address those concerns. Part of the reason for doing that is to raise awareness of what may not have been understood, or the scope may not have been understood at board level. So it's an important part of that. But the longer-term picture, the medium to longer-term picture, is the one that we focus on in the improvement portfolio, the improvement programmes, where we take the common and consistent concerns, and the one you've raised about dignity, compassion, behaviour of care, not just the techniques and interventions of care, and build them into improvement programmes which are designed to deliver higher levels of reliability and make the right thing easy to do. So changing processes which enable staff to more reliably deliver the right type of care, the right behaviour, the right outcome. If I give you an example from the Person-Centred Care Programme, which is a recently designed and launched programme, the interventions that have been identified as part of the bundle of changes that we wish to see teams make must do with me, is the terminology that's used, identifying the things that are critical, crucial and important, vital for that individual patient, not the collective or the group that happen to have a particular diagnosis. But for this individual patient, what must you do with me or for me? Accompanying that, a set of interventions which are around assessment of need and intentional addressing of that need. So not waiting for the buzzer to go because somebody needs help to be taken to the toilet, but on a 2-hourly or an hourly basis, asking that individual person, do you need help to go to the toilet? Is there anything that you need? Have you got the water that we know you need to take because your fluid intake needs to be increased? Another part of that is looking at the environment of care, not just for the ward, but for that individual patient. Is the buzzer on the same side of the bed as the chair in which the patient is sitting? Is the food or the water or the nutrition within reach? Does that person need help? Must do with me. I need help to eat this meal. Therefore, every time a meal is served, somebody must be there to help me take in the nutrition and the hydration that I need. If that helps, as an example.
When someone comes to my surgery and sees me about a relative or about their own care in the hospital, they tend to say two things to you. They explain to you what happened. They ask for your help to get an answer to why it happened, possibly to ensure that there's an apology if that's appropriate, and that some kind of system has been put in place to. And this is the crucial bit. What they will say to you is, I don't want this to happen to someone else. And that is always the hardest question for any of us involved in this system to answer, because I can't give that guarantee. I know full well that there are going to continue to be instances where people are not treated in a dignified way. But the best answer that I can give to them is if I have the raw data from bodies like yourselves that says, well, look, we know that we're not getting all of this right, but we are categorising these things and we are measuring over a long period of time in order to establish that it is going down. And if I can't give them that insurance, then I can't even begin to answer their question about, I don't want this to happen to someone else. So I think that's the key bit of it, because I absolutely accept this is going to be a minority of instances in individual reports. Individual wards are not going to be inspected hugely often. That's the nature of the beast. So unless we have a system of recording this information and analysing it against time, then we won't get anywhere. Is that fair? It seems to me that that's the way we would do it. But
if I may, I think that's a crucial point. We need to be able to measure against a baseline in terms of the changes and improvements that are brought to bear in NHS Scotland. We published in October the initial summary of the inspections to date at the 6-month point, and that's something we will continue to do, is to record where NHS Scotland is continuing to of areas of improvement, but also areas of strength. And that's something I think we'll be able to capture with the data that we collect as we further develop and evolve the inspection methodology, and then we'll be able to have a sense of that journey of improvement within NHS Scotland.
Yeah, just to underline that, I mean, as an organisation, we've developed our measurement capacity and capability, people with skills to measure the sort of things that you've highlighted. So yes, we will get data, national data from Information Services Division and from other national bodies, but how do we make the best use of the data that are coming through in the inspections and the improvement programmes? So we've invested in that area as an organisation. We agree with you that unless you measure these things, you don't know whether improvement is happening, and you cannot assure, in your case, your constituent, in our case, our patients.
I want to move on to ask something else, but just before I do, just to help me on the practicalities of how this all works, when you're going in to inspect a facility, a ward, or whatever it happens to be, what information does your inspector collate before they go? Because you'd assume that, obviously, if it's a follow-up report, you're looking at the previous report, but also as the organisation continues over time, you'll then have a bank of your previous reports you've had about that particular institution or that service that you'd want to have a look at before you go. Are you also, Dr Simpson talked about getting the information back from the boards about what they are getting complaints and comments about and praise. Are these all part of the things that the inspector looks at, or does he or she simply sit down with the checklist if this is what we want to see, and actually we'll look at it objectively on the basis of our checklist? Or are you going in with, well, we know there are concerns that have been raised in this service about X, and so I'm particularly looking to...
Part of the inspection process is, prior to the inspection, we review the self-assessment submitted by the board. That includes corporate data, it includes data that's directly related to patient care, whether it's audits, surveys, the patient experience. We use that. We use data from other organisations. For example, the Public Service Ombudsman, we get copies of their upheld complaints. We review that. We also review with our relationship with other organisations, carers organisations, we review that as well. And that informs our decision, and in particular it will perhaps inform what aspect of the inspection process but we will focus on, whether, for example, it's nutrition or pressure area care.
Helpful, and we can maybe pick that up with SPCO later. The other point I want to touch on was just around efficiency, and this is for your own organisation in general. So the convener touched it, quite early on in questions around the financial climate, the challenges that you're under. I just wondered whether or not you could give us any specific examples of the efficiencies that you've had to make, and if you maybe did two things. One would be to say, there might have been expectations on the organisation at the time you were coming together, and your predecessor organisations that you've now said they're no longer core and we're going to withdraw from that, but hopefully because someone else is better to do it rather than it's just, or it may be identified doesn't need to be done. So an example where you're withdrawn from something that either you previously did or there was an expectation that you would do, or someone within the new organisation previously did. And maybe also an example of, because I'm interested in this not just about how individual organisations in the National Health Service broadly respond to their own budgetary challenge, but how do we change across the board? So are there examples of something where perhaps the health board used to do this individually, but now you've taken it on yourselves, or another special board did and now HIS are doing it? Are there examples out there that you can share?
We've had a range of efficiency savings, not least the one where we've actually moved our headquarters from the centre of Edinburgh out to the Gaio to take part in shared services across a health campus, which has been a major efficiency saving. We've, as a board, we've become extremely robust as we brought in organisations. There were pieces of work, quite small pieces of work, that weren't really some of the strategic priorities of either government, ourselves, or the NHS, or the public in Scotland, but some project work. And in terms of efficiency, we've honed down to some key areas of activity, older people being one of them, that we would target our resources at. But Robbie, who's our Deputy Chair and Chief Exec at the moment, could tell you a little bit about our efficiency programme.
Yes, we've had a range of efficiencies over the past couple of years that have delivered probably a leaner, smaller organisation. And as Dr. Coia has referred to, there are some projects we've inherited from our predecessor organisations and taken the opportunity to consider as part of that prioritisation process. If I give you one very practical example, the work on the clinical governance risk management standards was subject to an extensive peer review process with the NHS boards. We've taken an opportunity to pause on that. The standards remain obviously extant, but in anticipation of the outcome from the Francis inquiry, there will be an opportunity to review how do we change and adapt in accordance with that and any findings for across the United Kingdom. So there are things where we have chosen to just perhaps pause and reflect upon, and areas where we've decided may not necessarily be a priority for us as an organisation. And that, again, gives us the headroom as Healthcare Improvement Scotland to have the capability and capacity to meet the range of requirements on us within the Act.
If I just a couple of small examples. We currently provide, as part of our Scottish Patient Safety Initiative, a raft of training programmes to build capacity and capability in the service. So developing skills and competencies both at board level and clinician level. And we're now working with our colleague in Education Scotland to transfer those programmes to themselves so that they will deliver those instead of us. Colleagues will also be aware that we work with Scottish Government so that teams, for example, the prison healthcare team that used to be a Scottish Government service was devolved to the boards, but we now have employed the core clinical staff, and in fact they play into our inspection processes for prison healthcare.
We've also taken the opportunity with some of our safety programmes. So Scotland is the only country in the world that has such widespread safety ambition, and we now have 6 national safety programmes. And rather than run them all individually with individual programme management resources, we've now condensed or truncated some of that to make sure that it's across the portfolio. And we work very closely with Scottish Government to gain their support around having that efficiency happening in the organisation with no detriment to these ambitious safety programmes.
No other members? Two final questions. I understand that there is a review of the methodology of the inspections, and could you tell us something about that? Who's on it? When we expect that to report? You know, I presume that that's to examine where we can improve the inspections and review that so far. And the other one important to us as a committee, and hopefully yourselves as the people who set standards, the committee into its inquiry of the regulation of older care recommended a review of the national care standards for older people that were 10 years old, and we would would like an update before you leave today about how that's progressing, your role in it, and when we would expect to see some fruit from that, and how you're working with the Scottish Government, who also accepted a recommendation there.
Start with national care standards, actually, because both the chair and chief executive of the Care Inspectorate meet with the chair and chief executive of Healthcare Improvement Scotland. We meet on a 6 to 8 weekly basis. One of the topics of our conversations has been the national care standards, because Scottish Government is carrying out a review, and we are going to begin to play into that review. We are very keen, both in the Care Inspectorate and Healthcare Improvement Scotland, that whatever is the outcome of the national care standards, that they include both health and care within them, so that when we start to look at these programmes of quality assurance across the community, the national care standards become meaningful for us across that integrated landscape. And we're very clear that we need to ensure that they're robust in picking up some of the issues you've raised around this table today, not only in inpatients but also out in the community. So we're playing in very strongly, but in partnership with the Care Inspectorate around that. And for us, that's particularly crucial for both organisations across the public sector, because as we move into the integrated services and look at how community planning and how the community health and care partnerships are going to start forming together, we need to be able to use the revised care standards as one way of quality assuring what's happening within those partnerships. So we're starting to work our way on that journey, and certainly as the integration agenda is moving forward, we're starting to almost run in parallel to try and make sure that's there by the time we get to the end point.
Has the review process therefore begun formally, or
not at the present? So, no.
And that would be the government that started that process.
Yes.
But that process has not started as yet.
Not that we're aware
the review.
of. No.
So well, it may be more appropriate to ask the Cabinet Secretary when that review would begin and why it's not begun. But that's fine.
In respect of the earlier question about the review of the Older People's Inspection methodology, it's being chaired and led by Pam Whittle, who's chair of the Scottish Health Council and also a non-executive on the Board of Healthcare Improvement Scotland. We've had 3 meetings of the review group since December, and the intention is we will have a revised draft methodology available next month.
And I presume that you'll send a copy to the committee for its observations and comment. Thank you all very much for your attendance here this morning. Thank you very much. I suspend at this point until we change the panel round. We now continue item 1, and our second panel today as witnesses is from the Scottish Public Service Ombudsman. Welcome to the committee, Jim Martin, Ombudsman, and Niki Maclean, Director, and Dr. Dorothy Armstrong, Nursing Advisor. Welcome to you all. And can I invite Mr. Martin to make some opening remarks before we move to questions? Thank you.
Thank you, Convener. The submission, the written submission which we made to the committee, we have focused on your request for views on the regulation of the care of older people in acute settings. But I'm more than happy to answer any questions about any other aspects of the health work that my office does. I found the preceding session extremely interesting, and I won't go over some of the points there because I'm sure some of them may recur. But I'd like to list maybe just a couple of issues for you which I think might be worthy of discussion this morning. The written submission that we've given you sets out some of our recent experiences. And you'll see that I say in that submission we're seeing repetition of incidents of failure to care adequately for people with pre-existing conditions in acute settings. Some of the cases that we see are extremely distressing. We don't go out looking for cases. We are very much a demand-led organisation. So the cases that come to us are generated by the public themselves and come through a process whereby health boards have seen these cases before they arrive at my door. So when I tell you that I last year upheld something like 56% of all the health cases that were brought to my office, which were fit for us to look at, that means that more than half the cases that I upheld had already been seen by health boards and that they had not upheld them. Now, not all of these cases deal with care for the elderly, but this particular area gives me great concern because many of the issues, as you said in your previous discussion, go to the basics of not only care, but human dignity. And that, for me, is quite distressing. When I first took up this post, I had a meeting with the Chief Executives of Health Boards, and I took Dr. Armstrong with me to make sure I didn't say anything wrong at that point. Now I only bring her with me to tell me that I've said things right. And I said to the Chief Executives that my predecessor had 3 or 4 years previously listed 10 key issues facing the health service as they'd come up in my complaints. And at that time, they were the same 3 years ago. 3 years on, they're the same again. And one of the questions that I have to ask about regulation and how we're doing it is, at some point, I think this committee and others, perhaps, may have to look at whether our regulatory model that we currently have is producing improvement and is operating efficiently. I think there's a question about quantity and quality. Last year, I chaired a regulatory conference of regulators across the UK in Glasgow. There were more than 200 people at the conference, and the number of organisations were numbered in the dozens. And one of my concerns, as I look at the cases that come into my office, is can I see the impact of regulation on the nature of complaints that are coming to me? And is there a danger that when we're looking at the health service, we're looking at it purely in terms of care provision and perhaps not recognising the impact on time of the people who work in the health service of a cumbersome, in my view, regulatory system and what often seems like overly complex management. One of the things that we find when we investigate cases is that we tend to go to the records of care. We make our judgments on fact, not an impression, on fact. And one of the critical elements that comes through is, do the people who work in the health service have sufficient time to address the issues that are in front of them? Because I don't think anyone goes into work in the health service saying, I intend to go in and operate with a lack of compassion today. I don't think that happens. I think the circumstances we find in many of our wards mean that time is of the essence. Now, Dr. Simpson in the earlier session made a valid point about the impact of boarding out of patients. And increasingly, we see people being boarded out into different wards, sometimes with cognitive problems, sometimes with a general amalgam of issues other than the ones they've gone to hospital with. And there seems to be a need to establish what the basic level of care for these older people, which these older people require in whichever setting within the hospitals they are, whether it's a hospital where they're going in to a respiratory ward for a respiratory illness, or if they go into an accident and emergency and find themselves, as I heard on the way in here, someone ending up, an elderly person, in a gynecological ward. The nurses and doctors in these wards need to be aware of the needs that these people have. I think a regulatory landscape needs to take account of the reality of what's happening on the ground. And I was very pleased to hear Robbie Pearson in the previous session discuss how Health Improvement Scotland are beginning to look at the patient journey. I think policy-centred regulation is perhaps a decent description of what we have just now. But I think a person-centred regulatory model might well serve us better, and I'm pleased that that's been examined. The point that Drew Smith made earlier, which is most commonly said to me, is the reason I brought this complaint to you is not for compensation, but to ensure that it doesn't happen to someone else, I think can best be achieved through learning the lessons of individual patients. So I think the process policy regulation versus personal regulation, in my view, is an issue when it comes to older people. And I think there is a need, and I get this not from the individual complaints that come to me, but from the noise surrounding the complaints from health boards and others. I think there's a need for people to listen more to the people on the ground who are delivering care. I think we have very often top-down wisdom where actually what's actually happening on the ground is being impeded by some management processes where the last people listened to are the people who have to deliver the service. And I say all that in general terms as impressions that I've gathered from the work that I've done and from having nearly 4 years now of being able to study the health service and how it responds to the difficult things that are brought to me. The last thing I would say is I was very pleased to hear our colleagues from Health Improvement Scotland say that one of the things that they would take into account when doing inspections would be the work that comes from my office. We are sitting on a database of real cases with real people which have come through, which we are happy to make available for people to look at when it comes to looking at inspections and working out when to do them, whether to do them and how to do them. So we're quite happy to help in that regard. But I think it's a timely discussion that the committee has brought about, because I really do believe that this issue is growing, not only in the number of complaints that we see, but in the public estimation outside of how they value the National Health Service.
Thank you. Our first question is from Drew Smith.
Thank you, Convener. I had intended to ask the panel a question about that interaction with Healthcare Improvement Scotland and how that fitted in to your own processes, but I think actually the Ombudsman has made quite a challenging statement to the committee, and I think I would probably rather stick with some of the issues that he has raised for the moment. So I suppose my question would be, how far along the road to a regulatory system, as you describe it, that is genuinely person-centred are we? And in order to get further along the road, what are the specific next steps that we need to take?
Having raised it, of course, I'm now going to dodge it. That is something I think that I'm raising because I would hope that this committee would look at. Because I do think you're in a particularly good position to take a view. Earlier, in your session earlier on, mention was made of the Crerar principles for scrutiny and the work that was done by Lorne Crerar and his committee, I think in 2007-8 probably now. One of the things that I think came out of that was that we, for 2 or 3 years, couldn't go to a meeting without people talking about cluttered landscapes. I think it would be an interesting activity for this committee to assess how the landscape lies today. Because not only do we have a number of bodies, not only regulatory bodies, but bodies who seek to influence what happens in the health service and elsewhere, but we also have remit drift in a number of cases where you see organisations were set up for a particular purpose and that broadens out. And someone, I think, this committee, maybe not, maybe the Scottish Government, I think needs to take account of how that is impacting, all that work is impacting, every bit of it good work, how that is impacting on the ability to deliver on the ground.
Could I ask you maybe a question? You mentioned in your opening statement that the Public Services Ombudsman has a database which you think tells a big part of the story about what is actually happening on the ground. Who uses that database at present, and what is your impression of how well it is used? Because you're right to say that Healthcare Improvement Scotland did say that they would want to look at that as a basis of thinking about some of their inspections and using it to inform some of their inspections. I mean, obviously the Ombudsman has now been around for a considerable period of time, and that is a considerable bank of knowledge. To what extent do we utilise it, do you feel?
The Ombudsman has been around for 10 years. This is our 10th anniversary year. In 2010, perhaps 2011, we were given power to make public decisions that we'd taken other than reports that we had laid before Parliament. So that every month, across the public service, we will lay a number of reports, now a relatively small number because we are working on the basis of putting important issues to Parliament. But we publish alongside them summaries, anonymised summaries, of our decisions over that period. And I know that tomorrow we'll be publishing, I think, 3 or 4 reports which will be laid before Parliament. And then I think it's 94, 95 summaries of decisions which we've taken in the last 6-8 weeks. These are all available and are being used. And I've taken the time to go around most of the health boards now in Scotland, and I'm encouraged by the number of nurse directors, medical directors and others who have voluntarily said to me that this is an important resource that they're using for learning within their area. And so from that is heartening. So that database is there in an anonymised form to be used. I'm also pleased that the Director General of the Health Service and others use it at their level to discuss with boards. And we have recently taken a decision, last year in fact, that when we do issue reports now to Parliament, we don't just send them to the chief executives of health boards now, we send them to the chairs of health boards, because we do believe that there are lessons to be learned from complaints. And I think Mid-Staffordshire is a very good example of where complaints were missed, to try to encourage that process. But I must make it clear, the Ombudsman's office is not a regulatory office. We are here to look at complaints that the public have not had resolved, to make decisions upon them, and then to tell Parliament and these people what our decisions are. But the information that we have, I would like to see more people use.
Do you think there is a difficulty in the specifics of complaints, I guess by their nature, are hopefully always going to relate to a minority of situations? We would certainly hope that would be the case. It would be something much wider going on if that wasn't. Does that make it difficult for us to put in place the kind of systems that then respond to what complaints are telling us? Because it is always easier to say, well, we appreciate that something went wrong in that individual instance, but we're fairly confident that across the board that wouldn't normally happen.
Yeah, one of the problems of sitting where I sit is you can get very depressed very quickly. because I see everything coming across the public sector where people are unhappy and things have gone wrong. And you have to keep a perspective on this. There's an awful lot going on out there which is done very well. But where we're going to learn is from the things that haven't gone that well and where they can be improved. It's also very tempting to make generalisations from individual cases. And we tend not to do that. I think since I've come into this office, I've issued 2 press releases. Only 2. One was criticising Greater Glasgow and Clyde Health Board, and one was praising Greater Glasgow and Clyde Health Board. One of them got coverage. So we're very careful not to go off half-cocked when we see something bad. We make sure that the recommendations we made are followed through as far as we can, but we have limited resource to do that. But in occasions like this, where we're able to contribute to something which you're doing and can go back and look at the experience that we've had over a period of time, I'm pretty confident in what I'm saying to you, that there are issues out there which are impacting on not just the care of older people, but other areas which I think this committee should look at.
Mr. Simpson.
Yes, Drew Smith's asked some of the things that I wanted to look at, but it's interesting that we heard this morning that HIS is not a regulatory body. And you're saying also clearly you're not a regulatory body. So when we talk about regulation in Scotland, I'm very slightly at a loss to know actually where it is. In England, it's very clear. There's Monitor, and that's, at the top of the pyramid, if you like, and they have the power to go in and actually say what should happen, and indeed fine boards or trusts or foundation trusts if they feel that something's not right. Now, I'm not suggesting that's the route we should go down, but you seem to be saying that we need to alter the regulation landscape in a significant way. Are you saying that we need to have a much tougher approach in these things, whereby advisory reports on inspections accompanied by an improvement plan from the boards, at the same time, and perhaps a follow-up, that really is not adequate in your view?
There are 2 things there. Let's take the first one. Lorne Crerar, when he did his review, I think quite carefully and helpfully talked about scrutiny bodies rather than regulatory bodies. And if you look at the impact of scrutiny bodies and the number of scrutiny bodies and what they're doing on the delivery of healthcare on the ground, I think that would be a valuable exercise to do 5-6 years after Crerar. And I don't think worrying whether I am a regulator in the Health Improvement Scotland sense or a scrutineer matters that much to the people who are delivering the service on the ground when that body or any other body, my own body, descends upon them. The impact, I think, needs to be looked at. As to whether, advisory or having more powers, one of the things I am frequently asked, in fact, I think at every committee I've been at in this Parliament, I've been asked, is do you think you have enough powers? Would you not be better having the power to direct people to do things? I'm changing my view on that. I've always been of the view until now that the powers of the Ombudsman are sufficient in that recommendations are carried out 90-odd% of the time. But I can, and I'm increasingly seeing this not in the health sector but in the local authority sector, becoming aware of people trying to test that. And I'm looking in my armoury and wondering what I have to ensure that things happen. So if I'm in that position, I'm sure other advisory bodies must be in the same position. But one of the things we must be careful of, and I think I said this in my opening remarks, is that we must be careful that the health service does not become over-managed with too many people directing things to be done And I heard, discussing with some of my advisors the other day, of an interchange where a consultant was in the discussion was asked not to refer to his place of work as my ward. You know, it's not your ward. You know, and if we're at that kind of petty level, on the one hand, it's almost laughable, but it goes to the convener's point earlier. What does it say about the culture under which healthcare is being delivered in our hospitals? What are the most important things, and what are the things which are taking up most time, and are they the same?
That actually leads very nicely on to my other question. I spoke in the Chamber recently. In fact, I got my figures slightly wrong. I was saying NSS Scotland, or it was reported as NSS Scotland. It should have been NHS Scotland. And it talked about bullying, and I was suggesting NSS Scotland are reporting 60% bullying. That was incorrect, and someone drew my attention to that in the last few weeks, so I need to correct it. But nevertheless, if you look at the figures of the number of people, staff that are reporting bullying, it's running at about 16% in the staff surveys. And more worrying than that, the number of individuals, the number of people in these surveys who are saying that they don't believe that their concerns were paid attention to was running at over 50%. Only 45, 48% said they felt their concerns were paid attention to. So my question, having corrected all that stuff, my question to you is, recognizing that's the culture that we're in, how do you think that we should be endeavouring to make further changes from your perspective? Are you getting, when you get into the complaints side, are you seeing staff saying to you, well, actually, yes, this was, you know, at a very frontline level, we'd like to have done things differently, but we were, because of time constraints, because of management, or because of direction, that we were actually not allowed to? In other words, are they feeling that their are you aware of that? Is that something that comes across to you, that the concerns of staff are not actually being met? Because it's going to get worse with austerity.
I'm in a position to answer that, because one of the things I'm precluded from looking at are issues of personnel, human resources, and that would include bullying and how staff perceive the management styles in different institutions. I have one observation to make, which may or may not be helpful. We talk about the National Health Service quite a lot, but actually there isn't really a National Health Service. There are a number of health boards, and within the health boards there are a number of hospitals and different areas, each of which has probably got a different culture. And the thing that impacts most on the people that bring things to me, in the terms that we're discussing today, is that it could well be the culture in an individual ward. And it can be about, or when people come to me, they're less interested in what the overall policy position of Greater Glasgow and Clyde Health Board is on a number of issues than the actual practice that happened in a ward at a particular time with a particular patient. And what we try to look at is, what were the constraints upon people at that time? Occasionally, I don't uphold complaints and people are annoyed with me, but very often we will take a decision in the context of what was happening in that place at that time, rather than an ideal. So in other words, the test that we will apply there will be reasonableness rather than ideal, and reasonableness will take into account occasionally other factors, such as, you know, someone didn't do something at a particular time, but that ward happened to be 2 nurses down in that period, and a clear decision had been taken to prioritise something else. And that is very important. I don't uphold everything that comes my way. One of the things I do tend to do from time to time, particularly if there's been a difficult bereavement, and all bereavements I know are difficult, is meet families where I have decided not to uphold their complaints and try to explain why. These are never easy meetings. People have a very, very strong view, clearly, on what has happened in these individual cases. But it's important that when people look at the Ombudsman's office, they understand that what we take is a balanced decision based on reasonableness. And that can sometimes be quite difficult.
When the complaints are upheld, do you get a report back saying that the individuals involved have been given additional training? I'm not really interested in disciplining them, but are they given the necessary additional training to make sure that they improve?
When we issue a recommendation, the recommendation will have a timescale attached to it. So, for example, I think you see cases that we have appended to the written report that we gave you. Each of these cases where we have upheld something, if we have made a recommendation, then the board will have been told this very clearly. The recommendation is that a psychiatrist or whoever should, at their next appraisal, have this brought to their attention and should be done, and that this should be done within X months, and then we will follow up to make sure that that has happened. Or in a broader sense, I think we highlighted in at least one ward, and perhaps even one hospital, an issue on pressure sores, and asked the board to review their policy on pressure sores to ensure us that they had done that and to give us evidence that changes had been brought about. So we will follow that up. But my organisation is a relatively small organisation. I do not have the resources to have my own inspectorate to go and follow that, which is where knowing that the Health Service and Health Improvement Scotland could pick up these complaints and recommendations and run with them, I think is very good.
Do they come back to you, Health Improvement Scotland come back to you and say, we've picked this issue of pressure sores?
Not as yet, but I was encouraged by what I heard this morning.
Good, that's helpful.
Boris?
Yep, yeah, really interesting. Just pick out one of the sentences from your submission, which I thought was kind of perfectly balanced and kind of demonstrates why we need the SPSO. There is always excellent outstanding care in the NHS, but we also need to recognise that it does not always reach those standards. And it's when we don't reach those standards that you learn, because it's dead easy to say things are going well, we don't have to change. And that was the conversation with Health Improvement Scotland. Even if things are okay, then okay is not the standards you're striving for, and you're always trying to get better care. So I was particularly interested in how not just Health Improvement Scotland, but perhaps the Care Inspectorate might use the data that you generate and the real-life experience you generate to the risk assessments they take to where they then apply their inspection regimes. And I think that's something as a committee that we would seek to maybe follow up on. We'll have to discuss that ourselves, obviously. That seems like a real concrete way forward for us. I was asking questions about the patient journey, and I'm just wondering if that's where you think, you've said in your submission that it's important, but I'm keen to get some more information on that and how you see it being taken forward and what you think the SPSO's role could be. I mean, I put on record what I think it could involve, but I'm more interested to know yourself as an ombudsman, how you would like to see it be developed, and are you content with how it's starting, from what you heard this morning from Health Improvement Scotland, and how they're starting to explore that pathway?
I think I heard a lot this morning from Health Improvement Scotland that I found quite encouraging. I think it may have been yourself who raised the point about the integrated health care, local authority, housing, and looking at the person in a whole. I think that's very, very important, because the understanding the context in which someone arrives in a hospital setting is important, and I understand that the point that was made about following from admission on, but it's important to understand at the point of admission what the circumstances of that person were. And it's always wrong to go to anecdote, I know, but anecdotally, I had a visit to an accident emergency unit where a very experienced consultant said to me that one of the things that he noticed most, one of the most significant changes he had noticed was when elderly people were being brought in from care establishments, care homes. In the past, someone may have stayed with them, which was helpful for the staff to understand the person and their needs and their background. But increasingly, he was finding people, were so pressed back at the ranch that they had to drop people and go, and then return to get them. And that suggests to me that at the point at which people are being admitted, we maybe are not joined up enough. I think that the point that was made this morning about understanding that someone who goes into a hospital for one thing may be bringing other things with them as being a core part of the care of that individual is very important. But I think if we think of it purely in silos in terms of health, social care, housing, then we will be missing a trick. I also had a discussion with one of my advisors recently where he explained to me that one of the things that he and his colleagues found most frustrating was that the pressure of work on social workers such that there can sometimes be a delay in having conversations with social work in some areas before they can get to a point where they feel safe to discharge someone from hospital. So I do think that increasingly the public are becoming aware of the joined-upness of care, whereas I'm not certain that we're always approaching how we're looking at and valuing and evaluating the care that's been given in a joined-up way. So I thought the discussion this morning, I think, was taken to a very good place.
You mentioned career, and you mentioned that well-used expression, cluttered landscape. Do you think that the example of the Care Inspector and Health Improvement Scotland having a multidisciplinary team to look at inspections in Perth and Kinross is a way of, don't want to say decluttering the landscape, but of rationalising the inspection process? Because you seem keen to say that inspection is important, scrutiny is important, but you have to make sure that it's done efficiently and it's done appropriately and it doesn't outweigh the benefits of frontline care.
And proportionate. I think it's important that it's holistic and that it's proportionate. I thought what I heard this morning is encouraging. I don't know any more than I've heard this morning, as I suspect some members of the committee may be in the same position. But I think if we are moving in that direction, then if the overall vision for the National Health Service in Scotland is to be patient and person-centred, then that has to be a step in the right direction, provided that it is not just another addition. So we're not just piling something else on top. At some point we need to have a qualitative look at what we're doing with scrutiny and the interventions that we're making to ensure that they are supplementing what happens in our healthcare and not diverting resource and perhaps diminishing the care that we can offer.
I suppose the only other thing I would ask, and I'll let my colleagues in after this, would be, you mentioned all the individual cases you have of complaints. Do you clearly analyse those and report, but do you make formal representations to the Care Inspectorate or Health Improvement Scotland to say, you know, the data is there, but we've analysed the data and we see a cluster of issues around X, Y or Z. We suggest that might be an area you want to go and look at further. Do you think it's appropriate for SPSO to make those types of recommendations, or to give the Care Inspector and Health Improvement Scotland the data and allow them to do that analysis? Where do you think the balance is between your role as the Ombudsman and their role as the scrutiny bodies on the ground for the delivery of care?
It's important to separate the two. I think it's very important that there's a public access route for complaints which are unresolved on health through health boards, and that comes to an ombudsman, and that is the final place for decisions, because an awful lot of these things require closure. And I think to confuse the two roles would be wrong. When Parliament looked, as it has done twice now, I think, since 2002 and the inception of my office, at the powers that my office should have, they were very careful to say that I should not have what other ombudsmen have in the UK, which is own initiative powers. And that is where you see a number of things coming through in complaints to then go and investigate, have an inquiry or whatever based on that. And also to make clear to the Ombudsman that the Ombudsman was not a regulator. So I have to walk a tightrope between the legislation that I have and what I see out there and what needs to happen, which is why this opportunity has been taken in the way that it has.
That's very interesting.
Just in respect to some of this discussion, you referred to in your submission the work that the committee had carried out in the regulation of owner care, and we've spoken about the National Care Standards Review after 10 years. Do you think that, I mean, it has been accepted by the government, but are you supportive of that review, and do you think that it could play into this sort of patient Pearson regulation? Is there an opportunity in there to develop some of your ideas?
I think every opportunity to look at this has to be taken, because one of my great fears about this issue is that it's a great talkable issue. We can spend an awful lot of time talking about this, and what we really need to be starting to think about is what the hell are we going to do about it, pardon my French. Because since I came into this office, it's being discussed. And before I came into this office, my predecessor was raising issues. And as we look around, this problem is only going to get worse. It's not going to get better. There are going to be more and more older people, and there are going to be greater expectations amongst the public about the care levels and the healthcare levels that they expect for older people. And frankly, that I expect for myself as I approach that kind of age. So I would encourage the committee to pursue the route that you're on and to keep pressing for improvements in these areas.
MacDonald?
Thank you, Convener. Obviously, we are about to embark on an integration process in terms of health and social care. Given the role that you have in terms of scrutinising both the health service and local government, I would imagine there would be an awful lot of information that could perhaps be gleaned from yourself regarding areas in both health and social care which perhaps need to be looked at as part of that process. And do you think that that's something that ought to be, that's a resource that ought to be being tapped into as we move the integration process forward?
One of the reasons I wanted to publish the decision letters that we've sent, as well as the parliamentary reports, is to get into the public domain the issues that are being raised by people with me that we're upholding. So from that point of view, yes. Well, one of the issues that concerns me in the role that I have is that there are 3 or 4 different routes that a person may take if something goes wrong. We currently in the SPSO are setting up standardised complaint handling procedures across the whole of the public service in Scotland based on the National Health Service model. So that from, I think, April this year, all of Scotland's local authorities will have the same model as the National Health Service. That should make things just a little easier to see how things are progressing. But in terms of my powers, if I can just look at the Ombudsman's office, he's an unintended consequence. If someone has a problem, say, affecting an older person, which may run across health and social care, and they take the issues through the health service complaints route, then I can look at the clinical decision-making of nurses, doctors, others in there. I can look at everything. If it's through the local authority sector, then the legislation precludes me from looking at decisions taken by local authorities unless there has been maladministration or clear service failure. And even then, if the decision that has been taken is a discretionary decision, then I may not look at it unless there has been maladministration or service failure. So in the context we are discussing, if that were in some area of social work that I might be able to look at, although I can't look at much in social work, I'd be fettered. The best case, if we take it out of health, the best case example, for example, is planning, where more and more decisions are taken by planning officers rather than by elected members in committee. If they have the discretion, by and large, I can't look at it. So in the integration, if someone has a complaint, depending on how they instigate that complaint and where they begin it, will determine how I may investigate it. So if they go one route, I may not be able to look across into something else. If they go other, I may be able to look more fully. So that is an unintended consequence of the legislation.
Can I ask further to that, and this might be a little bit on the parochial side, but in terms of arm's length organisations, what your role is, the reason I ask is that Aberdeen City Council, which is in the area I represent, has taken the decision to develop a local authority trading company, which would effectively make social care an arm's length organisation. What's your role in terms of arm's length organisations, and do you have any concerns around that in terms of how it would impact on the Ombudsman role?
Yes, my own view is if it's a public service being procured by a public body, then the service delivery of that should fall within my ambit. I can guarantee you that if I leave here and go back to my office, my legal advisors will be saying to me, on the one hand, Jim, on the other hand. So these things are not clear. When we have new methods of delivering public service, but we have public institutions which were set up and constituted in order to handle the old style delivery of public service, we inevitably find that that will happen. So the answer to your question is, I don't know, but in principle, my view is the public pound and the public service being delivered should be under as much scrutiny, in perhaps even more scrutiny, if it's been delivered arm's length, as it would be if it had been discovered by a body that's currently under my jurisdiction.
I think it's perhaps a matter I should pursue with you outside of this
Please
meeting.
Yeah.
But can I also ask, in your letter, you make the point that you do feel that, I know that in your letter and in your oral submission, you felt that there were areas where you had not seen improvement, as it were, or where you'd seen the same themes continuing to arise. But in your letter, you do say that there have been areas of genuine improvement. I wonder if you feel that there is, by and large, is the direction of travel positive, albeit slow, or are there areas where we are certainly still at the same place that we were a number of years ago?
I think that we are where we identify a failing. By and large, I'm confident that health boards will address that in the particular area where we've raised it. One of the good examples, when I mentioned two press releases about Greater Glasgow and Clyde, one was a horrific case of pressure sores. It was absolutely horrific. And Greater Glasgow and Clyde dealt with that very, very well. But of course, we still see pressure sores issues arising in health boards, including Greater Glasgow and Clyde. And one of my great drum-banging exercises is, are we learning the lessons? Are we making sure that the next person who comes into a ward in a different hospital, that the staff there have learned the lessons from the mistakes in the first one? So for me, part of my job is determining complaints, but an equally important part is trying to ensure that learning not only is recognised, but is applied from the experiences that the people who brought complaints to me.
And can I ask also, obviously you deal with individual cases that are brought to you. Are there points at which you would start to see individual cases developing into a pattern, for example? Now, we spoke about it may just be that it's down to the behaviour of an individual on a ward. But if you if you see cases from other wards within the same hospital or from other hospitals within the same health board which bear resemblance to each other, are you in a position, probably not within the individual reports because obviously you're dealing with that individual case, but are you in a position outside of those individual reports to raise concerns with health boards around what you see as a potential pattern emerging that they need to maybe look at and address?
Yes. Dorothy Armstrong, who's not only my nursing advisor but coordinates our advisors and her colleagues, will flag to me if they see things. I think we saw something in Borders a year ago, 2 years ago, where we saw incidents happening around a particular ward. And while we had not finished our investigations into the complaints that were brought to us, we were sufficiently concerned to draw to the attention of the Borders Health Board that we were looking at these things and we thought there may be something they should look at. So there is an ability when we see cases to flag things up. But please bear in mind these cases have already been through the health board. So the opportunity has already been there for the health board to pick that up.
Okay. Thank you.
Sorry.
Aileen McLeod and followed by Nanette Miller.
I think Dr. Armstrong wanted to add.
My apologies. Go.
Just to add to the Jim said around the themes, I think we absolutely see the same themes coming into the office, and we would feed that into the boards formally and very much informally, because we do a lot of our work is going out and talking to boards. And the example about pressure ulcers is something that has been targeted by the government in improvement, and we've seen a lot of improvement in the figures over the last couple of years. I think the one thing that perhaps continues to come up, and there has not been the same improvement, is about communication. And that's one of the things that in almost every complaint is something that's highlighted. And by that, I mean it's about the way people are spoken to, it's about kind of body language, it's about written communication as well. And that whole relationship with, whether it be a manager, a doctor, nurse, physiotherapist, is such an important part of the patient and carer's experience. And it's something that's also very difficult for us to measure and evidence. So it's not that we don't believe what complainants are saying, but it's something that is much more difficult to actually evidence and see. But almost without exception, the complaints that we uphold include issues about communication, behaviour and attitudes of people that are impacting on the patient's journey and experiences.
Aileen McLeod and followed by Nanette Millen.
Thanks very much, Convener. I just wanted to pick up some of the points that were made by my colleague Mark MacDonald regarding what you said in your submission about that there were areas of genuine improvement. And, for example, there is an evolving increase in transparency in the system, and we've seen that by the very fact that we've had the creation of Health Improvement Scotland since 2011. And last March, obviously, the previous Health Secretary ordered the NHS boards to undertake an internal audit of their management of the waiting times following the PricewaterhouseCoopers report on the management of waiting times in Lothian in March. And obviously the audit reports were published back in December when the current Health Secretary made a delivered a ministerial statement. Obviously this was the largest investigation into the management practices. And also the latest Scottish inpatient patient survey from 2012, which does show that their patient opinion is at a high level due to the improvements in the system. But the question I wanted to ask around was, obviously we've had the Patient Rights Scotland Act 2011, and obviously one of the aspects in that is the right of patients to give feedback, both positive and negative, or comments, or raise concerns or complaints about the healthcare they have received. And the Act also requires that health boards encourage, monitor and learn from the feedback and complaints they receive. So we just really to kind of ask around what sort of impact that's had upon your role, and also in terms of the kind of the complaints that you're receiving and the quality of patient experience.
I asked this question before I left my office, and we have got very little sense that people are quoting their rights under the Act when they come to us. And I think it's too early yet to determine around whether the move to pass has been effective or not. And I think it'll need to run for a period of time yet before we can determine that. But we had a 12% increase overall in complaints last year, and roughly that amount in health. This year, we were about 7%, 8% up. Now, either we're still not getting things right and complaints are going up, or people are more aware of their rights and are complaining, or neither of these. And something else is going on out there, because we're still getting an increase in local authorities and other things. So I think once we've seen the quarterly reports that come out and the annual reports around this, we'll have a better view. One area I do have a concern about, which I've raised with the committee, is I think an unintended consequence of the new system of feedback and concerns and complaints and compliments. In that now that the National Health Service has taken over prison health, there's anecdotal evidence to suggest that this has been seen as an extra stage in the complaints process, so that the feedback part of that becomes the first stage of the process before you move to a complaint. And I'm getting sufficiently concerned about that I've raised it with the Chief Executive of the Prison Service, and we're monitoring it very closely, because in the last year of the Scottish Prison Service health regime, 511 cases were reported to ministers for decision out with the prison. And the last number I saw for last year, which is roughly a year, was 46 coming out. So there's a disparity. We're either getting something very right, or there's something not quite working. So it may be that we have to look at how this is operating generally, but I'd be hopeful that patients would be more aware of their rights because of a discussion around the Patients' Rights Act, and that they would be keen to use PASS, and they'd be keen to use their pathways to bodies such as mine if they're unhappy with the boards. But as yet, I think it's too early to provide evidence of that.
Millen.
I'm interested in the paragraph you have where you speak about defensiveness on some health boards and how that can be a barrier to really getting to the nitty-gritty of problems. And you speak about there can be a complex mix of personalities, systems and resource decisions behind any issue. Now, looking ahead to the integration of health and social care, when you'll be not just dealing with the sort of health culture, but you'll be dealing with the local authority social work culture as well. Do you think that's something that's going to be compounded? Do you foresee any increasing problems as that integration goes ahead?
I'm not sure you can read across from the two. I think one of the issues in health boards is, although this is contentious, and I think people would disagree with me, I think there is still a culture in some senior areas of some health boards which are where there's a real fear of litigation, and that to admit that something has gone wrong would leave the board open to being taken to court or whatever. It is the most frustrating part of my job to have an advisor come to me and say, Jim, this is obvious. This went wrong, and it's pretty obvious it went wrong. I can recall one case where an advisor said, there's the x-ray. Of course it went wrong. And yet it had been through the whole of the board's procedures. And when we go back to the board say, yeah, well, we accept that. Now, it's good that they accept it eventually, but the patient has been through unnecessary stress, and the only reason I can see for that is not incompetence. I don't believe that. I think by and large it's a worry about litigation. So I do think that looking at no-fault compensation and looking at an appropriate means by which apology can be given, whether it's in the New Brunswick model or whatever, whereby people feel that they can say sorry. And I think the General Medical Council has got excellent guidance on how to say sorry. And one or two of our health boards actually are exemplary when things go wrong. I looked at a couple of apologies I saw from Highland Health Board, which were exemplary. I saw one that wasn't from the same health board. But when we get it right, we do get it right, and it means a lot to the people who receive them.
I'll leave it there just now.
Okay. Is there any other questions from the committee? Just in conclusion, I suppose many of the issues that we've discussed here about the pathways, the integration of care, are all of an interest to the committee, and I think in your evidence today and your written evidence, you can certainly have got something to say that's important to that process. And we heard earlier that the care inspector and his were meeting, albeit on a formal basis, informal basis, discussing some of these issues. Have you had an opportunity as an organisation or yourself take part in any of those early or informal discussions as we, you know, lead into the review of the National Care Standards and some of this debate that's going on?
We're aware of them, and I think we know how to input to them if we want to. I think we've been invited in the last few days to take part in the adverse incident review that Health and Improvement Scotland are conducting, and I welcome that because that's one area where it seems to me if we can take complexity out of it and put simplicity into it, it would really help a lot. So yes, we know how to get involved in these things if we need to.
Who is coordinating any of this in terms of, you know, the various regulators that are already in this field and advisory bodies that are in this field? And there seems to be a lot, and we all agree that they're important issues. We've agreed certain recommendations and reviews. It's all taking place, but it still seems a bit ad hoc.
I think we're a body which sits outside of all that. We're an arm's length body, who are here and willing to be consulted and willing to have input where that would be helpful. But I think that the bulk of the issues that you have been discussing are matters for the Scottish Government and the National Health Service to deal with.
Except that it may be something that we need to raise with the Minister. Can I thank you for your attendance, your thought-provoking evidence and your encouragement to the committee to carry on this work. Thank you very much for your attendance this morning. Can we now move to agenda item number 2, which is consideration to appoint a reporter. Members will have read the paper inviting the committee to consider to appoint Richard Simpson as a reporter to undertake a visit to Oldham, where there have been a number of successful initiatives with dramatic results to reduce numbers of teenage pregnancies. And Richard, can I call on you at this point to make some comment before I invite other members in?
I think the paper is a very useful one, indicating that, you know, Oldham is not the only area in which there have been improvements made, but they were one of the early ones that actually took this forward. I happened to be going down to Liverpool area over the weekend of that weekend of I think the first weekend in February, and I thought I would take the opportunity to go across there. But I then thought, well, doing that in a purely personal capacity would be one thing, but if the committee felt it appropriate that I should go as a formal reporter, then, you know, that might be worthwhile, and we could then have some formal notes sent back to the committee as to what they did and how they did it and whether it was a benefit and whether they're sustaining it, because I think it's all very well to do something, you know, and achieve something, but are they able to then, you know, sustain it and carry it forward?
Some comment from other members, or is there any comment, Bob?
Just briefly to say, if Dr Simpson's prepared to do that, I think the committee would welcome it. Just to add, as an aside, I am a lot more comfortable with the expression unplanned teenage pregnancy when we're talking about reducing, and I think the committee had used that previously, and there was some sensitivity around that, so just to put that on the record as well.
Okay.
Because I'm travelling down that area anyway, so save the Parliament a little money.
Okay then, we're content. Thank you very much for your attendance and participation and patience. Thank you.